I'm Dr. Mahadevan, and I'm joined by Dr. Matthew Strelo, who's going to be our expert for, or is going to provide expert analysis for basic life support case 1. Welcome, Dr. Strelo.
Thank you, Dr. Maha.
All right. And let's start up again with case number 1. This is a 54-year-old male with chest pain, diaphoresis, and shortness of breath. And let's just take a look and see what happens to this patient.
Still feeling okay?
How much longer am I going to have to wait?
Just a couple more minutes. We are very busy today. But you're feeling all right otherwise? Mr. Zambano. Mr. Zambano. Mr. Zambano? Oh, damn, Mr. Zambano!
Okay, so this patient, Mr. Zambano, doesn't look so well, and they show his monitor on the screen. So what rhythm is being portrayed here, Dr. Strelo?
Well, it's a wide complex, and it's a tachycardia. So, as you've probably heard me talk about before, wide complex tachycardia is ventricular tachycardia until proven otherwise. So there are some other things to look for or think about, but really that's number 1, 2, and 3 in this patient, especially a patient that's unconscious.
Okay. And then why is this patient unconscious?
Well, if you get ventricular tachycardia or potentially any non-perfusing rhythm, basically what's happening is the heart is going either at a rate that it can't tolerate, or it's not organized enough that the contraction is producing enough blood flow to the brain. The brain then doesn't function properly, the patient becomes unconscious. So what you really have to think is you don't have enough forward blood flow. Okay,
so even though the patient has a rhythm, it's not generating any blood flow to the vital organs.
Right, it's not a functional rhythm.
Okay, and so in this case, what should we do next?
Well, I think that he did try to see if the patient was actually unconscious, which is good, but the first thing I would do in that circumstance is I would call for help. I would, normally on most hospitals there's some system to call for help, and if you're not in the hospital, then you're going to call for help first. And then the very next thing I'm going to do in a patient like that is check for a pulse, right? Because I want to know, is the patient actually pulseless? Because that's going to change my management pretty drastically.
Okay. Sounds great. So let's find out what happens next. As Dr. Strelo mentioned, you've got an unresponsive patient. The first thing you're going to do is call for help. And then once you've called for help, the next step is to check for a pulse. And in this particular case, this patient did not have a pulse, and we had the benefit of actually seeing the rhythm on the monitor. Mm-hmm. So the final step in this pathway is to defibrillate this patient in this non-perfusing rhythm.
How are you doing?
Sorry. You need help?
I'm here. Are vital signs stable? Yes. Sir, you're going to be just fine.
All right, good job, Carter.
Yeah.
So
he seems very pleased.
He's very pleased with himself. So in your experience, is this realistic? Can you just shock somebody and then they wake up?
Not often. I think that, if you shock someone instantaneously after going into a non-perfusing rhythm, I have seen them wake up, maybe not that fast, but I have seen them wake up. But the vast majority of the time, they do not wake up and they remain unconscious.
So it really depends on the time to defibrillation.
Time to defibrillation, but the general rule is no, they don't wake up.
Okay.
Right? So you'd have to be in the perfect setting to get them to wake up.
And this was, in this particular case, this patient was in the hospital on a monitor. There was a defibrillator nearby, so different from the pre-hospital setting or the setting of the home or the field.
Or even most of the time in the hospital where the patient's not being talked to by a provider who knows what they're doing the minute they become pulseless and arrest.
Dr. Strelo, do you like to rub the defibrillator paddles before shocking? Does that increase the chance of...
I always like to rub just for luck, you know. I think that we don't actually use defibrillator paddles that often anymore here. We almost always use the sticky pads. If you do have the defibrillator paddles, the reason they're rubbing them together and the reason they did that wasn't to try to get some static electricity. It's actually to move the gel around. They would squirt gel into one paddle, and then you rub the paddles together to get the gel onto both paddles. So you're not rubbing them for luck, you're actually getting the gel moved around. But most of the time, you're just going to get gel on both paddles, get them in the proper position.
So if you're going to rub anything, it's going to be a rabbit's foot, right?
That's right.
Okay, good.
That's right.
All right, let's go on to our next case. This is an 82-year-old female with vomiting blood, and then they move her into another room and find out that her blood pressure is 80 over 50. They call another doctor to come see her. So let's take a look and see what happens next.
How much did she buy?
A couple hundred cc's all over Dr. Ross.
Okay, man, would you please take a deep breath? Good. Now another. Any pain there?
Oh.
Okay, how about here? Oh. Okay, it's okay. Call the OR, get a room. What is her crit?
23.
Whoa, wait a minute, here we go.
All right, they find out that she's been bleeding, her hematocrit's 23, and then all of a sudden she loses consciousness. So what should you do first in this circumstance?
Normally I say, here we go. I like to announce to everyone that this patient's sick, but I think we already knew that the crit was 23. So I think that I saw the doctor doing exactly what I would do there, which is as simultaneously as I'm trying to arouse the patient, I'm checking for a pulse.
Okay, absolutely. And in this particular circumstance, it's an adult who is unconscious. Where would we check for the pulse?
I go straight to the carotid because the organ that we're most worried about perfusing is the brain, and so that carotid is going to tell us whether we're going to be able to perfuse the brain. So. Absolutely.
And again, just as a review, when you're checking for a pulse, if we're talking about someone who's under the age of 1, we're always going to check in the brachial location as seen here, regardless of whether they're awake or not. Mm-hmm. If they're responsive and they're over the age of 1 or aged 1, radial, and as Dr. Strelo mentioned, if they're unresponsive and their age is greater than or equal to 1, you're going to check at the carotid artery.
She's Cody, cold blue. Call the time, it just happened.
8:37.
All right, paddles, let's go, people. That's a shockable rhythm. Let's go. This is the World's Fair. Let's move. Here we go. Nice and easy. Clear.
No response.
Okay, give me in.
Okay, so this patient is now in this rhythm. What does it look like?
Well, it's it's definitely a disorganized rhythm, and when it's disorganized, I instantly think fibrillation, and this would be called ventricular fibrillation, or some people might term this coarse VFib.
Mm-hmm. Great. And then the doctor mentioned this is a shockable rhythm. So what are shockable rhythms in the pulseless patient?
Yeah, so I divide this pretty simply into the patient's rhythms that will respond to electricity and those that won't. And the way I know that is if the heart has a rhythm that's disorganized, okay, then I want to shock it. And so a disorganized rhythm, if there's no rhythm present or the rhythm is organized, shocking is not going to help.
Okay.
So a disorganized rhythm is going to be a fibrillation or a pulseless ventricular tachycardia. So a wide complex ventricular tachycardia or ventricular fibrillation are shockable rhythms in a cardiac arrest situation.
Okay. And as you mentioned, rhythm present or rhythm absent. So you wouldn't shock asystole. We often see that on television programs, shocking asystole. What, any value to that at all?
No, there's been no value to that. In fact, they've changed, they don't even try to pace asystole. And that kind of makes sense if you think about it, because in asystole, the heart's not going to respond. There's no electrical activity. And when you shock a heart, what you're doing is hitting the reset button, just like you'd hit the reset button on your computer. You're actually resetting all the electrical pathways. And then the electricity needs to restart. But if there's no electricity being produced by the heart, then, like there is in asystole, resetting is not going to work, right? You have no power to turn on.
So you're saying that shocking someone's like a Control-Alt-Delete?
It is a Control-Alt-Delete for those of us that had computers a long time ago.
Dr. Benton, we got patients on surgical 2 and 3, and one of them looks bad.
Well, that's fine, but this woman's heart has stopped and she needs it pretty badly. Call the AR.
Now the residents are in surgery.
Well, get them out of surgery. Can't you see I'm busy? Time.
2 minutes.
Come on, sweetheart.
All right, it's been 2 minutes of CPR. So first of all, what do you think of Dr. Benton's chest compressions?
Well, the old bent elbow chest compressions, which you always see in these situations, is not very effective. And really, your chest compressions are the key to salvaging a patient. Basically, CPR is the key to salvaging a patient who's in a cardiac arrest. And so you need to have good, strong, fast compressions that compress the patient's chest a significant portion. You know, in an adult, you're going to go greater than 2 inches. The way I like to just think of it, though, is you just want to make a significant compression. And most of the time, unless the patient's very big, if you actually straighten your elbows out and lean into it, you will get enough. And then you want to get full recoil. The other thing that you see there is that you may not be letting up off the chest. So getting full recoil and letting the pressure off the chest fully is really important as well.
Great. And then it's been 2 minutes of CPR. What should we think about doing after 2 minutes of CPR?
Well, you need to reassess the patient. You need to see if any of your interventions or any of the things that you've been doing have helped.
Okay.
So reassessment, what does that include? Well, it includes making sure you've looked at the monitor, checking for a pulse.
Okay.
Okay. And normally I'm always going to check a central location as well. You got to reassess also what you're doing for the patient. So, you know, is Dr. Benton tiring out, and that's why he's not doing very good compressions? So should I switch the provider that's providing the CPR or the chest compressions? I reassess how my airway is doing. So I kind of go through my checklist of things. And at that point, I also decide whether this is a patient that will respond to medications and if I need to give any medications at that time.
Excellent.
Just a little nervous here. Okay, paddles, let's go. Clear.
Okay.
Is that a blip?
Recharging.
There it is.
Okay. Come on. Come on back to us. Come on, keep it pumping, keep it pumping. I think she's coming back. I think she's coming back, Taylor. Bring her back for me, baby. Come on back to us. Come on, baby. Yes.
All right, so they shocked the patient, and as you mentioned before, restarted the heart, went from asystole to a slow sinus rhythm, and then started picking up. But what should we be doing immediately after shocking a patient, even if they go into what we would expect to be a perfusing rhythm?
Well, this has been a good recent change. You know, we've changed over the last decade or so, which is what do we do right after we shock a patient and we get a perfusing rhythm back on the monitor? And a lot of times we check for a pulse and do all this other stuff and wasted a lot of time. And what we do now, and what is recommended now, is actually to initiate CPR. So you shock and then you start CPR right away. And that may even, keep you from seeing the rhythm exactly on the monitor, but that's not important. What we want to do is, once we've either cardioverted, defibrillated them, or shocked them, we are going to initiate CPR.
And the reason for that is that patients, once that they've started regenerating rhythm, their heart's kind of stunned. It really isn't able to generate a blood pressure. And so you're providing that blood pressure for the patient.
Yeah, it seems that the heart doesn't effectively start contracting because of the stunned myocardium for at least 2 minutes or so. So giving that 2 minutes of CPR is actually beneficial for the patient, even if they are in a perfusing rhythm at that point and their heart is working in an organized manner.
Great. All right, let's conclude with case number 3. This is a 75-year-old male found down, and CPR is in progress.
What are you doing?
CPR.
You can't possibly hope to perfuse the brain that way.
Perfuse the what?
Okay, perfuse the what? So this doctor's obviously upset with this person. Why is he upset about her chest compressions?
Well, as you can see there, actually she had a good straightened elbows. She was leaning over the patient. She may not have been coming off the chest fully, but the chest wasn't going down very much, right? She wasn't getting that greater than 2 inches, or like greater than about 5 centimeters. So the depth was inadequate. And what happens when the depth is inadequate or you don't come off the chest fully is you don't actually generate enough perfusion pressure, or pressure in the arteries, especially the coronary arteries, to perfuse the heart with good blood that's been oxygenated, and therefore you'll never get the heart back. So what you're hoping is that by doing CPR, you're perfusing the heart and the heart will come back, right? And if you can't get good CPR, if your chest compressions are inadequate like that, you're never going to do that.
So the depth was inadequate. What about the rate? Do you think the rate was adequate?
The rate was slow, right? So the other thing is that we know that with each compression, we can't get a lot of perfusion, so we need to keep the rate high to get the flow going. And so the rate should be at least 100 compressions a minute, okay? But that includes any stoppages and everything like that. So that means that you really have to be going at a rate of around 120 or so to get 100 compressions done in a minute.
Okay. So again, just to reiterate what Dr. Strelo is saying, you want to push hard, push fast, compress the lower half of the sternum, and your compression depth has to be at least 2 inches or 5 centimeters. Allow that chest to fully recoil for the heart to refill with blood, and you want to take the same time for both compression and relaxation. Excellent. What is the proper ratio of compressions to ventilations?
So it depends on the age of the patient, but in an adult patient, you want to do 30 compressions to 2 ventilations. So 30, what we call a 30-to-2 ratio. And so that's why you need to have people assigned directly to that, so that they're counting and they're focusing just on that, and not somebody like in Dr. Benton's case, in the previous case, where he's trying to think about everything that's going on. And because he's trying to think about everything that's going on, he's not doing great compressions on his patient, and he's probably not taking the time to count, and then he may not stop appropriately to do the ventilations.
Okay. Great.
Okay, step back. Step back. Who is she?
Who are you?
That's Mary. She's an EMT trainee, shadowing the nurses today.
Then you should be showing her the right way to do things. Okay, Mary, I'm Dr. Kovac. I'm the attending physician here and the ER chief, so let me train you a bit.
Okay, so showing us how to do it. And then let's finish up with this. What song from the 1970s allows you to keep the proper beat when performing CPR?
Well, I'm ashamed to say I was alive in the 1970s, and it was back in the disco era, so it was Staying Alive.
And you may not know this, but Dr. Strelo still listens to disco to this day. If you look at his iPod, it's on there, Staying Alive. So let's take a look.
Good trick is to pump to the tune of Staying Alive by the Bee Gees. Do you know that song?
Yes, yes, I do. I love that song. First I was afraid, I was petrified.
No, it's staying alive,
Okay. Yes,
staying
yeah,
alive.
You staying alive, staying alive. Staying alive, staying alive.
You can't tell by the way I use my walk. I'm a woman's man, no time to talk. Words it loud, women warm, been kicked around since I was born. Well, it's all right.
And that has been Basic Life Support, our expert analysis with Dr. Matthew Strelo. Thank you so much.
Thank you. Normally I save the celebratory dancing till after the patient comes back, but I like it. So thanks for having me. I appreciate